All right. Welcome everyone to the 2021 UNC Water and Health Conference. And thank you so much for your patience and joining the session today with me. I am Anjarul Islam and I work for the Water Institute at UNC. I'll be the room host for the session, for the poster session today. Before we get started, let's just quickly go through some housekeeping announcement. We will have lunch events every afternoon around 12:15 to 1:15. You will get that through Pathable. And we have an afternoon session for networking that will happen 3:30 p.m. to 5 p.m. Eastern Standard Time. That's available on Remo, and you will get all the registration related information on our website. We also have the late early show, which is just the recap of the whole session every day. Today we had a session regarding the South Asia region, and tomorrow tomorrow we'll have the Africa region perspective. We will hear from Farai, Angela, and also Tina Kanati Goda. Please feel free to join that session. It's very helpful if you are not able to join all the session on that day. A couple of quick technical instructions. This session is being recorded and the Zoom chat is being disabled. So please feel free to use our conference platform Pathable to type in any questions for our presenters. We will go with the questions with the presenters as time comes. Everyone but the poster presenters will gonna be muted. So without wasting any time, let's go ahead and start the poster presentation. We will go by Professor. We will start with Professor Joshua Garn, who is the assistant professor at University of Nevada, Reno. We will have a pre-recorded poster video from him and our technical assistant, Mary Margaret. We're gonna play the video now. Thank you. Mary. Okay, it's coming.
I'm Josh Garn, and I'm an assistant professor of epidemiology at the University of Nevada, Reno. I've worked on this project with collaborators from Emory University, from LMU Munich, and from the Task Force for Global Health, who I'd also like to acknowledge for providing funding for this review. Today, I'll be presenting on a systematic review and meta-analysis assessing the impacts of WASH interventions on preventing soil-transmitted helminth infection. Worldwide, it's estimated that 1.5 billion people are infected with soil-transmitted helminths. And even with deworming efforts, reinfection occurs rapidly, so interruption of transmission is unlikely without complementary WASH efforts. So we performed a review searching for all studies that had any sort of water, sanitation, and/or hygiene intervention, and soil-transmitted helminths as the outcome. We included both randomized controlled trials and non-randomized trials. The primary outcome of this study was prevalence of any soil-transmitted helminth infection. Secondary outcomes included prevalence of individual worms like Ascaris lumbricoides, Trichuris tricura, any species of hookworm, and we also searched for studies looking for Strongyloides stercoralis. We also assessed the intensity of infections for these same worms, with intensity being defined as a count of eggs per gram of feces for each species. For 30 studies that met our inclusion criteria, and 15 of them were randomized controlled trials, and 15 of them were non-randomized controlled trials. And these studies included 49,318 total participants. We found evidence in several areas supporting the impact of WASH on reducing soil-transmitted helminth infections. Among 13 randomized controlled trials assessing our primary outcome, pooled analyses revealed 18% lower odds of any STH infection among participants in WASH study arms compared to control arms. Similarly, among the 7 non-randomized controlled trials assessing any STH infection, the pool analyses revealed the odds of any STH infection that was 31% lower among participants in the wash study arms compared to participants in the control arms. None of the studies assessing individual worms showed a statistically significant preventive effect, the pool estimates generally were in the preventive direction. Our review found 16 studies assessing the intensity of infection. Individual studies assessing intensity of infection showed mixed evidence supporting wash. And data on intensity of infection were reported inconsistently across these studies, making pooling of the results infeasible for this outcome. So in summary, we found evidence supporting wash in several areas. Wash reduced STH infections, particularly for our primary outcome of any STH infection. This was seen both among non-randomized controlled trials and among randomized controlled trials. Many of these results were in studies coupled with mass deworming efforts in both arms, and therefore show the impact of wash above and beyond the application of mass deworming alone. And our review adds to the evidence that wash serves as a broad preventive measure for many diseases that have fecal-oral transmission. Thank you.
All right. Thank you so much, Josh. I would now request you to pull up your poster, and I'm monitoring the chat. Okay, we have one question came in for you. Did you look at the sanitation intervention in addition to wash? You think that water and hygiene would be less directly linked with STH?
Yeah, we looked at, we tried to categorize these interventions in a number of different ways. One of them was just any wash intervention. And then we also separated by different types of interventions to some degree. And there are a lot of different types of wash interventions, so it becomes really messy really quickly. And so I don't know if we saw any really clear evidence from any of the specific subgroups that pointed us one direction or another. But we did look at it. That's not a super satisfying answer.
Thank you so much for your response. Okay, as people are typing in the questions, I have one quick question for you. It seems like in your forest plot, we can see one has like negative odds ratio of -2, which is basic. Yeah. Do you have any explanation about that?
Yeah, there are a couple that seem to be kind of outliers in that they're much further to the left, and they also have really wide confidence intervals. And so what that means is that these studies were probably smaller studies. They're not contributing quite as much evidence to this forest plot. And so they're not going to be heavily weighted because of the width of the confidence interval. And so as we see smaller studies, we would expect to see sort of more random results, either in the preventive or in the other direction, the harmful direction. And so I think it's just sort of a function of the sample size in this case, probably. And it's probably not weighing that much into the overall results comparatively.
Got it. We have another question coming in from Eastward. The type of toilet, pour, flush, dry, UDDT, BIP, matter in the STH reduction?
Yeah, we didn't look at the type of toilet. Because of the number of types of interventions, it would be very difficult to, maybe we could probably do analysis looking at like improved versus unimproved, but if we're trying to pool studies that looked at specific toilet types, there are very few studies that looked at those different subgroups of toilet types. And so it'd be difficult to find a meaningful pooled analysis. You'd have very few studies in each of those different subgroups.
All right.
Although it probably, I can understand a mechanism where better toilet types could lead to a more meaningful impact. I think that's a valid point.
Okay. All right. I don't think there is any question coming in, but do you have any final thoughts about your poster? That would be great.
No, I think we're happy to see that, like many, we've worked on other systematic reviews in other areas, and I think um, the data show often mixed results, and I think those mixed results are due to a variety of things like poor compliance in trials and our inability to really implement interventions in a way that meaningfully changes wash between the intervention group and the control group. And we're happy to see here that once we pull these studies, that there is an impact on any STH infection. And I think it has a strong biological mechanism that supports that. And so we think that there's reasonable evidence to support that conclusion. Thank you.
So thank you so much. Uh, okay, now we're going to move on to our next presenter. Our next presenter will be Adnan Hakim. He works at a UNICEF Bangladesh. Mary Margaret, we're going to play the pre-recorded video for the poster. Okay.
From the UNICEF Bangladesh team. And today, on behalf of the SMOS study, which is conducted in Bangladesh, on behalf of the team members, so I am going to present you about the Bangladesh on-site sanitation status. Maybe you know, according to the JMP, still in the global, 3.1 billion people have the connection to the sewer system, but still 3.1 billion people are using on-site sanitation. And in Bangladesh, a specific context to the Bangladesh, so we have the 91% populations who are using the on-site sanitation systems. And so knowing the on-site sanitation service chain and its status and the safely management is very much critical for us. And this study is going to try set a baseline that we can in future planning and address the problem for achieving SDG 6.2. For this study, we use the method, it's called the mixed method, where we conducted the household survey. We also did the FGD, also we did KII. Beside of all things, we had to do the sanitation inspection to get the more authentic and quality data about the decision. And here, the 4 specific geographical area we targeted. One is rural, one is urban, and in between the urban, we try to see city corporation, small and medium towns, as well as the urban slums. And the objective of this study to getting the evidence and finally to prepare the SMOS definition and indicator for Bangladesh, data collection method and tools, and finally the way forward and what could be the monitoring mechanism for Bangladesh to trace safely managed on-site sanitation status toward the progress is to achieve SDG 6.2. And after the all study, 1.5 years study, the major outcomes of this study is we found like nationally only 10% population under safely managed on-site sanitation coverage in Bangladesh. In rural, which is 11, and urban, which is 10%. In general, it seems the urban and rural in Bangladesh, there is no disparity. But if you zoom into the urban, you'll see a different story. And urban, like the 10% population has safely managed on-site sanitation service, where a small town contributed the 18%, which is far up to the national level. In the medium town, it has the 13% population under coverage of the safety managed sanitation. But in the mega city and big city, where situation should be better, but we got only 5.7% people are under safely managed on-site sanitation. And if you look at the slum, this is the very shocking statistics. Only 0.5% population in urban slum have safely managed on-site sanitation services. And the major cause in the urban, rural, and all, as well as in the urban mega cities, the peoples are connecting their lines and to the directly discharge in the drain, and also the constructing the septic tank and the pits under their households, even if under their kitchens, and sometimes the toilet is totally top of the substructures, which is very difficult in future to access and doing the emptying and transportation or so forth. And finally, evidence shows for us, like sanitation technology for the containment to the treatment, this is not a big major challenge. The most challenge we found and identified, this is related to the enforcement of sanitation law and regulation, the public awareness. Government and the wash practitioners still have minimum know-how on sanitation service chain. So they are still on mindset for the sanitation coverage. And also the lack of administrative monitoring mechanism and the authenticated quality assurance of the safely managed sanitation services. So in conclusion, we can say achieving safely managed on-site sanitation may be very challenging unless all concerned people, including local public representatives, government officials, civil society, and the most importantly, the users are sensitized of the benefit of complete chain of safely managed sanitation services. So I am stopping here. Before that, I just acknowledge and thanks to the JMP team, Bill and Melinda Gates Foundation, and Bangladesh government to support us. Thank you.
Thank you so much, Adnan. Would you mind pulling out your poster in front of us so that we can see that? Okay. Okay, cool. Nice. Now I can read that. Thank you. It seems like people are typing in. I can just go ahead with my first question. It seems like uh, cost is a factor here. Um, can you just briefly tell us how much cost is associated with the emptying and what is the average income of your like sample size, if you know?
Yeah, the actually the costing for emptying and this is also related different type of technology. So what type of technology you are using, right? And we also found still in Bangladesh most of the people are using the manual emptying. So in terms of that costing, this is very minimum to emptying a one pit and dispose in somewhere. It's costing a unit cost like the $5 around that. And in the big cities nowadays, they are using the mechanical emptying, but still this is very less. We found like the only 9% overall emptying service in the mechanical, and rest of rely on the manual emptying. So this is the another part we have to be improved in future just to move. As the manual emptying, we found this is very difficult to ensure the safeguards and the all safety measurement. Despite of the your safe containment, when it goes to the empty, most of the time it's diluted the environment and polluted the overall surrounding, and it turns to the unsafe practices. So that is, did I miss your another question?
Yeah, my another question is, what is the average income of your sample size?
So honestly, we didn't calculate that one, and it was not the part of the study boundary. So we divided on the wealth quintile, but didn't go to and look at the income and the average income part.
Okay, got it. Thank you so much. Okay, I can come up with another question. So on the graph, I am actually having a hard time understanding what is CCRES and CCLIC.
Okay, here is the CC means the city corporation.
Okay.
So and city corporation residential area, which is the higher quintile of the people's living. And also we try to see the in between the city corporation, there is the low income community, which is called the LIC. So the disparity and the status of safely managed sanitation systems. So we try to split the city corporation into the strata.
Got it. Thank you so much. All right. Thank you so much for your
Thank you.
poster, and thank you so much for being with us. I think it's late night in Bangladesh. But
Yeah.
thank you.
Thanks. Thanks a lot.
Now we will move on to our next presenter, Medin Ricau. She's a PhD student at Tufts University. Mary Margaret will gonna share the pre-recorded video. Thank you.
I'm going to talk about the development of WASH guidance that is context-specific for the control and elimination of cholera. So with the support of the Global Task Force for Cholera Control, countries that are facing cholera are developing national cholera control plans that include WASH guidance. But WASH in cholera interventions are not always replicable across different contexts, even in one country. And so guidance on how to choose and implement WASH interventions, depending on the context of cholera, is necessary to help develop the WASH part of the NCP. So for this, we developed a multi-step method. A working group was set up to collaboratively develop the guidance. A literature review was done, including WASH in cholera guidance, NCPs, and a systematic review of publications on WASH in cholera interventions. Key informant interviews with the working group members were done to collect information on WASH in cholera interventions and cholera context definition. And based on this review, the key informant interviews and the working group experience, a guidance is currently being developed. So the poster presents the results from the literature review and the key informant interviews. For the literature review, 36 manuscripts, 6 guidance documents, and 4 NCPs were reviewed. The peer-reviewed manuscript mainly focused on evaluating the effectiveness of WASH interventions, both in emergency and in context with recurring cholera. The guidance documents focused on outbreaks-related activities, and the NCPs focused mainly on WASH related to the SDGs, so more long-term outcomes. Overall, the themes that emerge are that cholera occurs usually with or directly after another emergency, that targeted interventions are more effective, like case area targeting, and that collaboration with the health sector is necessary. The context also needs to be thought of in a broad way, including many factors such as previous interventions or community attitude. For the KRIs, 18 interviews were done. 26 themes emerged from these interviews, and these were divided into 5 categories. So we found that the context can be defined by the objective related to the disease. So do you want to control the disease in an outbreak? Do you want to prevent cholera before the cholera season? Or do you want to eliminate the disease in the long term? Then there are factors defining the specifics of a local situation that will influence the type of intervention that can be implemented. So these are like, do you have access to the beneficiaries? What are the existing infrastructures? What is the funding available, etc. Then we identified circumstances that are usually used as context, like development, urban, com settings. So they have similar characteristics, but they are too broad to effectively select the appropriate WASH interventions, and they can overlap one another. Then there are factors that emerge that are influencing the successful implementation of WASH interventions. So these are monitoring of activities, collaboration with the health sector, mapping of cases, and targeting of activities. So to select the appropriate WASH in cholera interventions related to the context, the objective regarding the disease need to be defined first. Then the specifics of the local situation will influence the type of interventions and how to implement them. And then the characteristics related to the broader context will help guide the selection of interventions. In both the literature review and the key informant interviews, we saw that similar themes emerged, like the collaboration with the health sector and the targeted approaches. So the next steps are now to develop the WASH guidance in collaboration with the working group members. Thank you for listening, and if you have any questions, don't hesitate.
Thank you so much, Thank you so much, Marin. As people are typing in the questions, can you just share your screen and pull up your poster in front of us? That would be great. Wow, thank you. Uh, hmm. Okay, I can come up with one. I can see that in your results for disease control, it seems like water quality is important, but wondering why sanitation is not the priority. For my understanding, I think sanitation is somehow related to water quality. I'm doing some sanitary inspection analysis, and we are trying to find out that if sanitary inspection has anything to do with the water quality monitoring and things like that. So I would be happy to hear your explanation.
Yeah,
Thank you.
sure. Thank you. It's a great question. So what we found is that in the systematic review, the interventions that were evaluated, none of them was related to sanitation. As we can see here in like the charts, it's hygiene and water treatment interventions only that were evaluated. And then in the key informant interviews, what we found is that for an outbreak, most of the informants said that sanitation is not the priority because it's not what is going to have the most impact, like the fastest and the because sanitation takes a long time to improve. So it was more identified as important for like elimination of cholera or prevention, but more like long-term interventions. When there is an outbreak and you have to act quickly, you go for water quality, you go for hand hygiene, this kind of thing.
Okay, interesting. We have one question coming in for you. Ryan asked that, how do you use the coding to determine the intervention, since the codes are not necessarily mutually exclusive? If you would have a
Sorry,
rule,
how do I use, do we use what?
how do you use the coding to determine the interventions?
Yeah, so some codings were already pre-identified, and then it was through the analysis. So we did the analysis through in vivo, qualitative analysis, and some coding, like some context just emerged, like for example, control and prevention of cholera were some of the themes that emerged. So basically, the development, urban, rural ones were the ones that we had already coded, like selected, and then all the what we call the decision factors, so like the existing infrastructures and habits of the local context, the source and transmission of the disease. These were themes that emerged during the analysis of the key informant interview. So it's what people kept talking about, actually. And even what was interesting is that the informants didn't always identify these as context, but it's just that they kept saying the funding is important and it influences what we can do. The source of the outbreak will influence what type of intervention we can do, etc. I don't know if that answers the question.
Yeah. Also, can you just quickly and briefly tell us about the two? Is that a pie chart? I'm not sure. Yeah.
Sorry. Sorry, what was the question?
So yeah, can you just briefly tell us about the like two pie charts, intervention in emergency settings and then intervention in endemic settings?
Yeah, sure. So these are the results from the systematic review. So we separated the interventions that were evaluated in emergency settings. So these were when it was kind of an outbreak of cholera, and not necessarily when cholera was coming back every year or every so often. Whereas endemic setting, the second pie chart, was in context where cholera was recurring year after year or very regularly. So we can see in both of them that it's hygiene and water treatment interventions that were mostly evaluated. And it was more water treatment in emergency settings and more hygiene in endemic settings. And in both, there's like chlorination, like household water treatment was evaluated a lot, bucket chlorination for emergency settings. In hygiene, it's mainly hygiene promotion that was evaluated. Yeah, and bulk chlorination also for emergency settings. So there are some similarities between both settings, and some interventions were more evaluated in emergency settings. What we found is that, sorry,
Yeah.
what we found
Okay,
also
yeah.
is that,
Yeah, it's really resourceful, and thank you so much.
Yeah.
Now we're gonna move on to our next presentation. Our next presenter will be Sebastian Rowan. He is a PhD candidate at University of New Hampshire. Mary Margaret, whenever you are ready, please share the pre-recorded video.
Hello, everyone. My name is Sebastian Rowan, and I'm a PhD candidate in the Department of Civil and Environmental Engineering at the University of New Hampshire. I'm also currently working on this project as an ORISE Graduate Research Fellow with the U.S. Army Corps of Engineers. The purpose of this project is to improve the way the Army Corps of Engineers conducts flood risk management projects by developing strategies to incorporate impacts to human health into flood risk assessments and associated cost-benefit analyses. We know that floods are associated with adverse physical and mental health outcomes, such as injury, spread of infectious disease, depression, anxiety, and post-traumatic stress disorder. Despite this knowledge, engineers lack methods to predict these outcomes from flood events. This means that decision-making for flood risk management projects tends to be driven by assessments of impacts that are easily quantified in monetary terms. Just for a bit of background on the Army Corps planning process, project alternatives are assessed using 4 accounts of public benefit: net economic development, regional economic development, environmental quality, and other social effects. This 4-account framework was developed with the goal of ensuring that projects were designed to maximize public benefit in all forms, instead of just monetarily. However, a lack of guidance on how to quantify and compare benefits across these accounts has led projects to rely almost exclusively on the NED account for decision-making. This project contributes to a broader USACE effort to address this limitation of the framework by systematically reviewing the relevant existing literature to define relationships between flood exposure and adverse health impacts. To gather the literature for our review, we performed a structured query keyword search in 2 citation index databases, Web of Science and Engineering Village. This search returned nearly 4,000 unique records, and by reviewing the title and abstract of each article, we excluded about 3,700 and imported the full text of the remaining 231 articles into NVivo for content analysis and coding. We coded article contents into 4 broad categories: exposure, which captures details about the study area and study population, such as age and gender distributions; hazard, which captures details about the hazard event being assessed, such as flood depth or rainfall duration; outcome, where we capture the outcome or outcomes being assessed in the study; and relationship, where we capture details about the analysis performed in the study, such as how factors captured in the other codes are related to each other and any quantitative or qualitative findings. Unfortunately, at this time, this content analysis is still ongoing and we don't have results from the synthesis to report. Instead, the figures on the right-hand side of the poster show preliminary results from the coding. Of the articles coded so far, 71% have assessed at least 1 mental health outcome, 55% have assessed at least 1 physical health outcome, and 41% have assessed at least 1 other non-health outcome that we felt may be relevant to future work in this area. PTSD has been the most assessed mental health outcome and the most assessed outcome overall, being included in 40% of the articles. The next most frequently assessed mental health outcomes have been depression, distress, anxiety, psychosocial resource loss, and substance abuse. Loss of life has been the most assessed physical health impact in 21% of the articles, followed by injury, cardiac conditions, chronic illness, infectious disease, and respiratory conditions. Of the factors assessed as influencing these health outcomes, age and gender have been the most common at 43% each, followed by home damage, income, education, and race or ethnicity. Next steps for this project are to complete the content analysis, including a second wave of relevant articles that we identified by reviewing the bibliographies of each article included in the first wave. Once this is complete, we will perform a qualitative synthesis of the findings from the full text analysis to identify the most common health impacts from floods and the factors that most contribute to these outcomes and identify areas of future research need. We also plan to conduct a quantitative synthesis of the research findings to develop empirical relationships that can be incorporated into engineering risk models. Our expectation is not to develop complete predictive models for each of the health impacts identified here. Rather, where possible, our goal is to determine the likelihood of a given health impact based on other direct impacts for which models currently exist. For example, what is the likelihood that a person develops PTSD given that their home has experienced significant flood damage? Thank you for visiting this poster session. If you're not in the live session, or if I'm not able to get to your question, please feel free to send me an email at sebastian.rowan@unh.edu. Thank you.
Well, we are very fortunate to have you here, Sebastian. Can you just share your screen and pull out your poster in front of us? Great, thank you. Okay, so I have a quick question. I'm having a hard time understanding the difference between PTSD, depression, and anxiety, distress in mental health outcome, and who actually identifies those indicators?
Right, so those are the specific outcomes that were defined by the authors in the individual studies that we reviewed in this literature review. And I should just be very clear, I'm an engineer, and so I have learned a lot through this process, and one of those things is that moving forward in this work, it's going to be very important that we not be too overconfident in our ability to talk about medical research. And so I don't think I'm really qualified to go into too much detail in the differences between PTSD, anxiety, and depression. So I don't think I'd feel really confident in that at this time.
Yeah, I'm also an engineer. That's why I'm just having a hard time understanding that.
Yeah, and I think maybe I could just, and maybe instead of answering your question directly, say this, obviously working with the Army Corps of Engineers, the conceptualization for this project before we started was really in the kind of the mindset of an engineer, where I think we thought that we would go in and find relationships with flood intensity and outcomes similar to how you would measure damage to a house or other physical infrastructures, where you could just find data on the depth of a flood and then the rate of these outcomes. Mm-hmm. And so what I mentioned in the video presentation of not trying to develop these full models to predict these outcomes, I think a more useful outcome of this research is to present the real complexity of this issue to the engineers who are making these decisions, to help them understand that it's not such a simple relationship, or simple, say in quotes, as it is kind of in the existing methods that we use right now. And I think that points to the need for a lot more work in who is making decisions in engineering practice and how and when we're incorporating different data sources.
Got it. Thank you so much, Sebastian. I think people are still typing in their questions, but I can go with another one. On the first graph, what does that mean, the non-health outcome? So.
Right. So as I mentioned, the 4 accounts that we use to measure benefits in projects, the one that this project is really focused on is improving that other social effects account. And so health impacts is a big part of that. So, and our primary focus here was to try to find quantitative relationships and understand how floods impact health. But a lot of the studies that we've looked at have, along with health impacts, also looked at things such as how floods cause businesses to close or cause people to lose income. And those are things that they're outside of the scope of what we're looking at in this project. But that's definitely useful information for that other social effects account. And so we wanted to code those articles and retain that information so we could maybe go back to this in future work as we try to bring that OSC account into more use in the planning process.
Yep, got it. Thank you so much, Sebastian. Maybe we'll have question for one, but we are not seeing anyone. But I would love to request Adnan Hakim to come in forward and to answer one of the question asked before after the session. From Rick, he said that you found the best results in small towns. Any explanation to that?
Yeah, actually, the small towns, those are almost similar to the rural area in Bangladesh. This is the first interface between the rural to urban part. So their sanitation structures is same part, and the technology they are adapting, this is similar to the rural, like the pit latrine and the twin pit latrine. And those towns still have the low densities of the population, and also their economic status and the lifestyle is the part of like the extended part of the rural. So this is the reason, like where the a small town is counted under the urban statistics, its high figure reduce the urban statistics and make it much more better in total urban blanket. And that is the reason to understand the real challenge where urban is facing the challenge for the sanitations. We divided it to the mega cities, the slums, the small and the rural. And we found actually if we want to focus and change the sanitation and turn to the safely managed, we have to focus more on the city corporation where is the highly densitized areas and also the slum areas. Then the statistics will be really reflect the urban context. Otherwise, it will be the misleading context.
Wow, thank you so much. Thank you so much, all the poster presenters. I would request all of you to go into our Pathable chat platform. If there is any question unanswered, please feel free to answer those as you are available. Now I want to share our special thanks to our speakers, the audience, and also our sponsors. Without them, this event would not be possible. And also, please stay tuned. There will be a networking event. Will gonna happen in just 1 minute. It will gonna happen in 3:30 Eastern Standard Time. Yeah, thank you so much, everyone, for joining the session with me and having your time today. Thank you. Bye-bye.